Welcome to Acute Conversations, the official podcast for APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Nicole.
And I'm Leo. And in today's episode, our guests are Caitlyn Crandall and Lindsey Fresenko.
Today, we discuss the core outcome measure set for acute care and its use in clinical practice, all the way from the ICU through med-surg and into discharge planning. Hope you enjoy the show.
All right, welcome. For today's episode, our guests are Caitlyn Crandall and Lindsey Fresenko. Thank you so much for joining us today for our episode. And the reason that we're bringing you on board today as guests is because you all have a webinar that you're going to be teaching for the APTA Practice Committee that's scheduled for November 20th. Is that right? I should know because I'm helping run it. I'm going to be there. And I forget, East Coast time, what time did we have at the start of the webinar?
Is it 7?
I think it's 7 p.m. We'll make sure that's in the show notes. But this is a big topic. So basically the core outcome measures set for APTA or for acute care therapists. So the first thing I just kind of wanted to ask is, how did you get involved with the research for the core outcome measures?
So we were both acute care residents, and the core team realized the undertaking of the project. And I know I had just started, I think I was 2 months into my acute care residency after graduation from PT school, got the email, was like, I've always been interested in research. This might be something worth exploring. So my co-resident Darby and I joined in.
Wow. And then Caitlyn, go ahead.
Same for me. So I was doing my acute care residency at NYU, and like my, mentor program director brought it up to me. And I joined it as a residency project, and it continued past residency, which I don't think any of us were anticipating how big of a project this was, but it started in residency, and it's just, it's been a journey, but a good one.
Definitely. I do remember going to different CSMs and talking to different researchers that were involved with it. Shout out to the Kirby Mayer, and then our former podcast co-host, Ashley Poole, was also involved with looking at these core outcome measures. It's been definitely a process, right, for putting this all together. So, in preparation for the webinar, one thing I wanted to ask is, just in terms of outcome measures, we always hear excuses of why therapists probably don't use outcome measures. Especially, I would say therapists are just kind of set in their way. So we were talking before we started recording. What are some of the excuses that you've heard of not using outcome measures, and what response do you have to that for those that don't use these outcomes?
I think the biggest one that I hear is time. Like, we all know productivity standards in acute care can be difficult to meet. And, people are always concerned about meeting productivity and therefore the time it takes to do these outcome measures. But what we need to remember is that this is stuff we're already looking at, we're already assessing. So it's not essentially adding additional, or, you have to assess mobility and then do the outcome measure. You can, assess the outcome measure during your session, essentially.
And I would just add, I think, as silly as it might sound, some of the barriers can be, is there a prompt or a cue to remind me to do this? If you have an EMR that's more of checkboxes or, fill in the blank or dot phrases, it might not be something you think about, because we are very mobility driven, which we know is really important. But some of these outcome measures that have, come to the top from evidence in our core outcome measure set include bed mobility, they include transfers, they include gait. So like Caitlyn said, it's just really putting a number to it so we can kind of try to start standardizing care and then collecting some of these outcomes to see how it impacts patient outcomes.
Fantastic.
I know you two will cover this in depth at your event coming up, but can you give us just a sneak peek of what outcome measures are highlighted in your paper?
I was going to say, you probably
haven't read
it. You might be able to guess one. It's highly researched. It came to the top. So unpack, 6 clicks, is one of the ones that's most heavily researched and had a lot of psychometric data that supported it, which is one of the variables we looked at. The other part was kind of clinical utility. So can we use this? Is it a tool that is quick, efficient? Again, kind of speaking to things we're already doing. So that is one of the outcome measures that came up, which if you've gone to CSM or any other webinars, you've heard of the unpack. There are a lot of hospitals already using it. So it's not necessarily recreating the wheel with that one as well.
Yeah, and then we also have some, like unpack is one of the core measures. We also have some supplemental measures that might be, ICU specific, and just kind of looking at unique areas that maybe the core set address, like the 6-minute walk test for endurance, or the SPPB.
What was that last one?
SPPB.
Short performance.
Okay.
Battery? Short battery? Yeah. I always mix up those terms.
It's the short physical performance battery.
There you go.
I don't think I was familiar with that one. That's one again. I was just telling Caitlyn online, like before we started recording, I'm like, you all have changed my practice, and that's part of the reason I like being part of this podcast, is just knowing that like there's a lot of things that I don't know. So I like to surround myself with very smart people, so I can educate myself. So it is a selfish measure. Nicole,
I have a follow-up question too. Is that okay, Leo? Yeah. So these outcome measures are wonderful. How do you envision, like when you're using them in an acute care setting, how is it different than when you're applying an outcome measure in an outpatient setting? Like fundamentally, what is different?
I think a lot of these outcome measures, especially the unpack, help in terms of discharge recommendation, which, when you're using them in an outpatient setting, you don't necessarily have that factor. Another thing that, I work in the cardiac ICU specifically with a lot of pre-transplant patients, so we also use them pre and post-transplant.
And then I think for me, the difference is too, a lot of these outcome measures, you don't need a lot of supplies necessarily. So they're also quick to do, at least a lot of the ones we identified in our core set. So if we compare it to maybe the Berg, which has a lot of steps, can be time consuming, in acute care, because we want to make the most of our time and productivity, like Caitlyn alluded to, I think that is something we try to keep in mind with the recommendations.
So for example, like if you're doing the SPPB, the short physical performance battery, and you get through one part of it or two parts of it and you can't complete it, do you get credit for doing that outcome measure in acute care, and how do you document that?
Yeah, so go ahead, Lindsey.
No, I was just going to say, we actually use this measure in our post-ICU patients. So when I was at the University of Kentucky, we had a post-ICU recovery clinic. And this was one of our kind of core set that we did with every patient. And I would score it for what they could or could not do. For me, I was in a place where I could get through everything. I had time for that. But maybe Caitlyn can talk to, if she runs out of time, how she would score that.
So for like the SPPB in particular, it doesn't take a whole lot of time, and there are there is an option if the patient can't do it, or if it's not safe, it's like a 0. So that's factored in. I don't find it takes like I said, like a lot of time. So I don't see that as a problem. We use that. I never used that at NYU, but at UNC, we use that for one of those like pre-heart and lung transplant measures.
Thanks.
Nicole, I wanted to ask you, just in terms of your experience of working in the acute care setting and working with acute care PTs, what's been the reaction towards use of outcome measures, or kind of implementing standardized use across the board? Has it been met with some resistance? Are therapists open to that?
So I would say in the practices that I've had in acute care, which have, spanned across the last 15 years at 3 different hospitals, outcome measures have really started to come to the forefront so that we can assign value outside of productivity. We can demonstrate the outcomes and the products of what we're doing. We've seen all that through combined sections meeting, and we will keep seeing it hopefully in the acute care side to help shape our staffing and justify the wonderfulness that we bring to the comprehensive team in acute care. I think one thing that I always think about, and maybe this is controversial, maybe the two of you are going to be able to educate me a little bit, but sometimes I feel like we maybe throw the baby out with the bathwater on outcome measures in acute care when, okay, a Berg is a lot of steps and it could take us a long time. There's an incredible amount of value in doing 3 of the parts, or, how we use a tug or a cognitive tug to help make decisions around, is this patient prioritizing their safety and can they go home? And looking at that, but maybe it's not done perfectly by the book for research quality in acute care, but maybe that's okay too. Maybe that's a wrong opinion though. What do you guys think? Correct me.
I think it's twofold. I know personally I have used parts of the Berg or the DGI, for example, with gait training, that maybe I didn't do the whole standardized outcome measure, but there is value in assessing some of those components. So from a clinical perspective, I have used it in a way that's not standardized. On the flip side, having worked through this project with this core outcome measure set, I think something we're trying to promote is that standardized use and scoring, because I learned a lot in terms of there's standard chair heights for some of the sit to stand measures, even just with gait speed, the different, lengths and kind of how we look at those different populations. Like I learned so much about that. So I see the value in following that standardized protocol, but I also can see where components of these tests can also be really beneficial into your clinical decision making and showing progress with your patients too. So I'm going to advocate for more standardized use, but I also think it can go both ways.
Yeah. And I would also some of these outcome measures, parts of them, like we said, are already what you're doing. Some of them, certain parts can be a great intervention. And also specifically in terms of this outcome measure, like the Berg, takes a long time. All the outcome measures that we've included in our core set and our supplemental were specifically chosen because they don't take a whole heck of a lot of time. They're clinically feasible. In terms of the standardization, I know, during some of our CSM presentations, we had other PTs who were in the audience who were very passionate about why this one outcome measure wasn't included. And, we do need that. It just advocates for more research, which we need standardization for. So I think that's another thing that this core outcome measure set in CPG can hopefully promote.
Yeah, I mean, you're creating a starting point, a diving board to go into even deeper of a mode. I'm very grateful for this work that you're doing. Don't get me wrong. I just also know in practice, it's hard, and we do have reasons why. The focus in acute care is really, we're triage essentially. How do we help this person get from here to the next level of care? And I think we sometimes lose the content and the value and the intervention of what we do because we're really looking at a discharge rec or a length of stay or, whatever the case may be. So I'm grateful to have these tools in place for us to see what difference we really are making bedside.
And I'll say I also really appreciate that you took that into consideration, that this is not an article that's written by people that only do research. In terms of understanding the types of tools that you chose, you wanted to make sure that it was clinically relevant and also feasible, right? For example, yes, the Berg is a great tool, but for your regular acute care therapist, having to walk down to the rehab gym and find a tissue box and find some cones, where's the steps? Okay, we have to walk 300 feet to go find to the next stairwell to go up and down the steps. So in terms of the feasibility, I think that's great that you kind of honored that. And so now that we know that the ones that were chosen that kind of rose to the top, these are the ones that we can, again, relatively simple to be able to add and maybe change a little bit of that, some practice patterns. But again, it's still a challenge. Now, one thing I think that's changed, I think just from the education standpoint, are a lot of students are being exposed to outcome measures sooner rather than later. I do know that at the University of Illinois PT program, we try to incorporate, even at the very beginning, just getting familiarized with gait speed or like the tug. I wanted to ask you, what experience have you had kind of talking with some of the different DPT programs or lecturing as guest lecturers? What have you been seeing in terms of the importance of outcome measures and teaching to the new therapists that are coming through the programs?
So like we were talking about before we started this recording, I gave a lecture at UNC to their DPT students, and it's an entire class that's just focused on outcome measures.
Wow.
I didn't mention that part. Yeah, so that's pretty cool. And some of these students were talking about various outcome measures that they use during their clinical, if they had an acute care clinical before. So it's great that they're being exposed to different outcome measures, and they're talking in this class about the clinical utility, the research, why they might choose one outcome measure over the other. So I think that's wonderful. I know in my PT school we were taught outcome measures. We were taught kind of like the basic ones. Like I remember learning about the 6-minute walk test. I don't think we learned about unpack. So I think that's a change that will hopefully keep going, so more students are exposed to the outcome measures before they get to their clinicals or their clinical practice ETs.
Mm-hmm.
And then I'm in a full-time professor world now, so it's been really exciting to see how we are from the very beginning talking about evidence-based practice and psychometric properties and kind of analyzing the evidence, and then all the way up until their second year into clinicals. How do we actually use these outcome measures, and how do we decide which ones are most appropriate for our patients? Like that's also a component of it. We use the neuro core set. Well, now we have the acute care core set. So in my coursework, I get to talk about, a core set that I worked on, which is really, really cool. I don't think the students recognize how cool that is, but I think it's really cool. So I think that it's definitely something we're trying to emphasize the value of, and having them decide to clinically, why is this important as well? So hopefully, 10, 20 years from now, we see that shift with a lot more data on outcome measures. And then also they're just an everyday use in practice. It's not even something we think about anymore.
Right.
Is there some intentionality behind bringing this to the clinical instructors as well, so that knowledge translation can go into practice?
So I know the Acute Care Academy, while we were in this process, there's a knowledge translation group that are working on kind of how do we take this core outcome measure set and actually put it into practice. So what are some resources? What are some things we need? As Caitlyn alluded to, we took notes at all of our CSM presentations to kind of hear these barriers, hear the facilitators. I know I just gave a journal club to our OTs and PTs in acute care at our hospital, just to kind of educate them. And then we're going to do a competency and kind of expect everybody to be competent with the core set. So as far as clinical instructors, I don't know if we're being directly intentional yet, but I think there's value in that for sure.
I also think that, PTs who pursue, who really want to be a CI, I feel like they are, the type of person, the type of PT they always want to continue learning, continue their own knowledge. So I feel like, hopefully they're looking at this and bringing it into their practice independently and passing it along to their students.
Agreed. And hopefully the students are bringing it up with them.
Now I want to play a little bit of devil's advocate in terms of outcome measures, right? So let's flip it again, because of course, we as acute care therapists, we love this stuff. But I also think that it needs to be said that, for example, if I use only one of the outcome measures, and maybe I'm using unpack, and based on the unpack numbers, if I look at the numbers by themselves, could I cite, well, because they scored this, this patient has to go to a skilled nursing facility, right? I don't think that's the right way to use them, hanging all of that information just on using one and just that specific number. But I also feel that's the nuance and the skill that we bring along as acute care therapists. What's the right outcome measure to use in this specific situation? There's patients that are the 6-minute walk test would be a great outcome measure, right? Versus the DGI or the short form DGI and gait speed. But can you talk a little bit about where that the nuance between, okay, we don't put everything, just the numbers kind of help, right? Having something that's objective, but we also can't be all this one outcome measure. We're going to hang all of our decisions just on this single number.
Yeah, I think the AMPAC is like the big one in that in terms of discharge, because we have research that, certain AMPAC scores are predictive of discharge, like disposition. Like I said before we started recording, after my lecture with that, outcome class at UNC, I had one student who said that, at the small community hospital, she did her clinical at patient's discharge. Dispo was only based off their AMPAC score. And the AMPAC score doesn't take into consideration everything. It doesn't take into consideration like their support at home, their home setup. And so, I mean, that's where that clinical decision making also comes in. I think it's important that we realize that these outcome measures aren't meant to replace the physical therapist's clinical decision and recommendation. They're meant to support it.
Mm-hmm.
And
yeah. Go ahead.
Sorry, Nicole. I was just going to add too, I think, some of these outcome measures, we miss the cognitive component, or we miss the safety component. Some of them look at fall risk, but that's just one component of safety to go home if we're thinking that the goal is, to help patients get home. So I think that is one thing that Caitlyn alluded to in terms of the outcome measures. I think something we tried to keep in focus too when we promoted this core outcome measure set of like, why do we need it, is there's still autonomy in practice. Like, this is a guide, but no one's going to be mandating that you have to do all of these on every single patient, because there are patients that it might not be the best measure or the most appropriate for. Hence why we had the supplemental set, because we know that there are patients that might be better suited for the 6-minute walk test versus the AMPAC doesn't tell you much because they might be a 24 on the AMPAC.
Mm-hmm. Mm-hmm.
Yeah, I was going to say, so are you saying, we can still recommend acute rehab on a patient that scores a 22 out of 24 on the AMPAC? And what does that look like as a frontline clinician? If I'm standing at a multidisciplinary round and I just scored my patient as a 22 and I'm still saying rehab, what do I need to do? What do I do?
And I think that's where figuring out how do we highlight, because I run into that with patients on, like, for neuro patients, for example, where they can walk 400, 500 feet standby assist, but they don't know the difference between a toothbrush and a stack of cubes. This is a real patient that I treated. So I think that is sometimes hard to highlight. I know during residency, that was something that challenged me. It was like, how do I write a good assessment to actually drive home my point? But I think there's cognitive outcome measures that isn't a construct we looked at with this core outcome measure set, but and then it also plays into that interdisciplinary communication. So one of the core set that we identified was solely focused on improving mobility, communication between patients, providers, and like other interdisciplinary team members. So knowing that if we give a certain score, what does that actually mean about what they can do today? Because we know that there's value in understanding that, and that the number only goes so far. But I know that comes up all the time.
Yeah.
Yeah. And I would say, like, literally just this morning, I scored a patient, I believe it was 17 on the AMPAC, and still recommended acute rehab, just because this patient is so far away from their baseline that I still think acute rehab would be appropriate, even though, they're able to do a lot of things with contact guard or standby assist. They're still very far away from their normal.
Yeah. And I do think, personally, I wasn't part of writing this, so I think you're certainly way more educated in this topic than I will be or have been. Maybe that's where we have the opportunity to pull in other narrative components where we show, for example, a tug or a tug cognitive, and that patient, that you throw the cognitive task at them, and then they don't prioritize safety and they start falling, right? They choose to keep walking at whatever speed while answering your questions, and they, demonstrate significant sway. So although on the surface in a closed environment of a hospital with flat surfaces and, without animals running around their feet, they look and feel okay, safe. And for those that are just listening audio, I did put the air quotes around the word safe. It seems like a dangerous word these days. But yeah, I think outcome measures only demonstrate our point in a stronger way. It shows that, we are educated, we're using literature and evidence to guide our decisions, but it is not where we hang our hat.
Absolutely. And so, Caitlyn and Lindsey, I also want to ask you, throughout your research here, has any of this changed your practice? Because again, like after reading this, I'm like, oh, I can add this onto my, in terms of the outcome measures that I use consistently. How has this changed? And Nicole too, has this changed, like after reading this, has this changed the way you approach your practice?
So I've always used the unpack every single session at both the institutions I've worked at. I think this has changed my use of ICU specific outcome measures. To be honest, like before starting this, I was not aware of, any ICU specific outcome measures, but now, I am, and I use them in my practice along with the SPPB. I use that one a lot, and the 6-minute walk.
And I was going to say I think the biggest thing I kind of took away is understanding more about those psychometric properties and like the constructs we're actually measuring. So like, in PT school or early on, lower extremity strength or endurance, but actually putting that in the context of the ICF and understanding what that's telling me about that patient from some of these measures, getting into the data. And I know Caitlyn and I, one of our roles is kind of oversee some of this data extraction and collection. So got very intimate with all of the articles in this paper. I think it made me kind of view outcome measures in a different way than I had before. As of, I get this score, maybe more surface level of they're a fall risk. So they score this on the tug, they're a fall risk, period, But okay, well, what does that actually mean? And if someone else does this test again and they get a different measure, or should they get the same measure if it has good reliability? Or if we're looking at predictive validity for AMPAC, for example, understanding that, but also seeing like how many articles actually looked into that. I think that's what really has changed my eyes with these outcome measures.
So I think one of the strengths that this article brings to light too is conformity across practitioners in acute care, and gives us kind of a common language that we can come back to. I'm curious, how do you document, like what metrics or properties of these outcome measures are you putting in your notes? And then, the follow-up question to that would be, is there a place where the acute care practice or in your outcome measure where you've created a template or something that we can share that's deliverable to our frontline clinicians to make it even easier to tell the story?
I know, like in our paper, we have the data for PTs to look at. In terms of documentation, like just as an example, with the AMPAC, when we document it, we use Epic, and there's like a percentage that gets pulled through with whatever AMPAC score it is, saying this, this patient is X percent impaired. And I think that gives some context to the interdisciplinary team that might not be that familiar with the AMPAC.
I'm hoping something, maybe this is a call out to the Knowledge Translation Committee, just to see what they're developing, because I am interested for some of those tools, because I know some of the healthcare systems are kind of trying to create in their EMRs ways to kind of auto-populate some of these core outcome measures to kind of, automatically be in there for you to think about as a clinician, like, oh, maybe I could do a 5-time sit to stand, for example. And then if I do that, could I do a short physical performance battery because it's 2 more steps? Kind of triggering some of those thoughts in your brain. I also think that like we talked about, the score itself, So one of the outcome measures in the core set, I'll give another spoiler, is the Johns Hopkins highest level mobility. And that was the tool that we're looking at to kind of create an interdisciplinary communication. And I know my healthcare system here is trying to create a kind of like a light color system for, providers and the nursing and the nurses to see what color they are and then know what level of mobility they can actually engage in. And I know other healthcare systems have tried this or maybe are very successful with this type of communication. But I think that's just one component of how we can start actually implementing it and then seeing it benefit the patients at the end of the day.
Great. Thank you.
Mm-hmm.
That's awesome. Well, Caitlyn, Lindsey, thank you so much for the work that you've done and the research that you've done regarding the outcome measures. And thank you so much again for being willing to host the webinar for APTA Acute Care's practice committee. So again, that's November 20th. Hopefully some of y'all can join us. It's gonna be a fantastic seminar. They didn't give away they didn't show all their cards. There's still plenty of information. This was just a teaser.
Yes.
And on that note, we're gonna end the podcast and we're gonna move on to our rapid responses. So Caitlyn, Lindsey, the way we do this is that Nicole and I are gonna ask you some rapid fire questions. You just answer the first thing that comes to mind. It's rapid response. Okay. Nicole, are you okay taking the first question?
I am, sure.
All right. Let me set up my timer. Let me set up my timer first. All right. Okay. Caitlyn, Lindsey, are y'all ready?
Yep.
All right. And go.
All right. What is the dumbest way that you've injured yourself?
Oh my gosh. I fell off my horse. My horse stopped and I kept going.
Oh no.
Yeah.
I stepped on my own pinky in middle school and broke it.
What's a movie that you can quote endlessly?
Oh God, Madagascar.
Okay.
I was gonna say National Lampoon's Christmas Vacation.
Fantastic.
That's a good one.
Obviously. If you could be invisible for a day, what would be the first thing you would do?
No.
Monitor therapists and make sure that they're using.
Yeah.
I was gonna say probably
Make sure they
eavesdrop on some conversations.
Oh. Do you want me to go again, Leo?
Oh, sorry. Who's your celebrity twin?
I've been
gotten
told
Julia Roberts before for me, but I don't see it.
I've heard Zoe Deschanel.
Very nice. What's the worst haircut you've ever had?
When I got bangs straight across.
Yes.
I cut my own bangs when I was like 4, so that was probably the worst.
All right, and now that leads us to our final question. You know that you're working on a care win. Complete the sentence.
Thinking, I said you lead a parade down the hallway of like ECMO with the perfusionist and, the patient on the vent with RT. And also that you need to have spare clothes and shoes times.
Absolutely.
And mine was whenever you're carrying socks in your pocket all day.
Yes.
There we go.
Pulling them out. Socks for everybody.
No, I don't have to leave because or when I'm working with students, I'm like, carry some extra socks in your pocket because they're going to come in handy and you're going to increase your efficiency.
Yes.
Awesome. Lindsey, Caitlyn, where can if people have questions for you all, how can they reach you?
I can give my email and we can put it in the notes, or I'm more than happy to field any questions. I also want to give a plug for the webinar. We'd love for it to be discussion based. We have some application and we want to hear your thoughts because CSM, we had a lot of good conversations, but now that it's out, we want to hear what you think now that it's in the world.
Fantastic. That's great. And Caitlyn?
I would say the same. I'm happy to give my email for the show notes, but I think the best way is to show up to our webinar. Like Lindsey said, we're really hoping that opens up a lot of discussion and that won't be like, the last stop of the discussion. We hope it keeps going.
Awesome. Well, Caitlyn, Lindsey, thank you so much for joining us today for the episode. And hopefully we'll see you and everyone else and all the listeners November 20th.
Congratulations. Thank you so much.
Thank you.
Thank you.
We would like to thank Caitlyn and Lindsey for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leo Arguelles and Nicole Neveau. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for another engaging acute care conversation. Thank you for listening, and may your shoes and scrubs stay clean today.